For given cases, a 60-year-old male with refractory depression is scheduled for electroconvulsive therapy. Except the electroconvulsive therapy consists of programmed electrical stimulation of CNS to initiate the seizure activity. Let's see discuss about anesthetic goals and considerations. Anesthetic goals include rapid and smooth induction, adequate amnesia, adequate muscle relaxation, airway production, prevention of complication, rapid and smooth emergence. Anesthetic consideration are difficult history taking, drug interactions, short duration of procedure, anti-aspiration prophylaxis, hemodynamic alteration, use anesthetic drugs which do not alter seizure activity, to peri-procedural complication. We should consider associated medical condition which increases perioperative risk, which are unstable or severe cardiovascular disease, space occupying intracranial lesions, unstable vascular aneurysm, severe pulmonary disease, recent cerebral hemorrhages. Let's come to pre-op evaluation. History taking. We should evaluate coexisting CNS diseases, CVS diseases, osteoporosis, and fragile bones. We should rule out contraindication for VCT. We should medications. Next comes to investigations. Routine blood investigations, ECG, chest X-ray, renal function test, and then comes about pre-op psychotropic drug administration. Drugs to be continued are reuptake inhibitors, sertraline, fluoxetine. Selective norepinephrine reuptake inhibitors are duloxetine, venlafaxine, and drugs to be continued are tricyclic antidepressants, which are amitriptyline, imipramine, desipramine, and monoaminoxidase. It should be continued preoperatively only if anesthesiologist is familiar with MEO safe technique or withdrawal of the drug will exacerbate the depressive symptoms. Antipsychotics include clozapine, quetiapine, olanzapine, risperidone can be continued. That to be withheld or lithium. 1 to 2 doses are withheld preoperatively. Anticonvulsive mood stabilizer include valproates also should be withheld. Benzodiazepines should be tapered and discontinued prior to the planned ECT. MEO inhibitors, timing of discontinuation. Moclobemide stopped 24 hours preoperatively. Drugs to be stopped 2 weeks prior to surgery are tranylcypromine, phenelzine, isocarboxyacid. 3 medications. NPO for 6 to 8 hours. Informed written consent. Anticholinergic medications, which should be used only for patients with a prior history of severe bradycardia during electroconvulsive therapy or excessive elevation during ECT. Drugs used are IV glycopyrrolate 0.2 mg IV, IV atropine 0.2 to 0.4 mg. Sedatives, especially benzodiazepines, are avoided due to risk of delayed emergence and increased seizure threshold. Anti-aspiration prophylaxis 0.3 molar sodium nitrate, sodium citrate 50 ml, metoclopramide 10 mg IV. Headache prophylaxis. Headache is the most common adverse effect of electroconvulsive therapy. Ibuprofen used prophylaxis. IV ketorolac can be used. OT preparations. It refers skilled assistant, emergency drugs like beta blocker, nifedipine, IV NTG, airway equipments include handle bag, airway, face mask, laryngoscope, EP, and finally defibrillator. Choice of drugs. For infection, metronidazole is a drug of choice. 0.75 to 1 mg per. Other advantages include minimal anticonvulsant effect, rapid onset, and short duration. Its disadvantages include reliability, and it can produce myoclonus. It reduces seizure. Seizure duration. Next induction agent is etomidate, 0.152 to 3 mg per kg. Its advantages are it reduces seizure threshold and it prolongs seizure duration. Its disadvantages are hyperdynamic response, longer emergence time, increases muscle tone, post-operative nausea vomiting. Other induction agents are propofol, 0.75 mg per kg. It reduces post-operative nausea vomiting and faster emergence. Its disadvantages are pain on injection, short acting, significant anticonvulsant action. Next is thiopentone, 2 to 5 mg per kg. It has longer depth of anesthesia compared to propofol, but it can cause rising intracranial tensions and the emergence agitations. Ketamine not used due to adverse cardiovascular actions. Muscle relaxants. Succinylcholine is the drug of choice. 0.5 to 1 mg per kg. It can also produce partial block, which reduces electroconvulsive therapy seizure. But its disadvantages are it can raise intracranial pressure and intraocular pressure. Mivacurium 0.15 mg per kg can be used, but it may need reversal. Other agents, remifentanil, it attenuate hypertensive response to seizure. Caffeine, it prolongs seizure. It is used for seizure augmentation. Monitors input, ECG, non-invasive BT, pulse oximetry, visual observation of limb for duration of seizure, electroencephalogram for central seizure, electromyogram for peripheral seizure, and comes to procedure. Pre-oxygenation, maintaining with 100% oxygen saturation. Injection, IV propofol in absence of metronidazole. Neuromuscular blockade, as already discussed, in a IV succinylcholine is the drug of choice because it minimizes the risk of physical trauma. This usually arises due to uncontrolled tetanic muscle contraction. Airway management. Patient ventilated with oral airway, face mask, and self-inflating blood. In endotracheal tube intubation is usually not required as procedure duration is short. Endotracheal tube used only in presence of increased risk of aspiration like pregnancy, GRD, hyperthermia. The ringing mask airway may be useful in patients with a difficult mask ventilation. White block. Can be inserted post-induction in order to prevent dental and soft tissue injury. White block should be made of flexible material. Ventilation and oxygenation. Ventilation with 100% oxygen ensures hyperoxia. Hyperventilation is used prior to delivery of electrical stimulus. This induces moderate hypocarbia with N-title carbon dioxide of 30 mmHg. Hyperoxia along with hypocarbia increases seizure duration and intensity. Electrical stimulation. Stimulus applied through 2 electrodes based on the patient's care. If seizure begins, it is terminated with the IV discipline 5 mg. Hemodynamic management. Parasympathetic responses of motor nucleus of vagus nerve and the nucleus ambiguous of medulla oblongata. It is self-limiting. If persistent, we can give atropine to treat the bradycardia. Sympathetic response is increases in heart rate by 20%, increases in systolic blood pressure by drugs used or IV esmolol 0.5 to 1 mg per kg. It can be repeated every 3 to 5 minutes. IV metrolol 1.5 mg followed by 5 to 15 mg 6 hourly. IV levetolol 5 mg repeated every 10 minutes up to 300 mg. Sodium nitrophytate 0.1 to 3 mg per kg per minute infusion. Calcium channel blocker IV nicardipine 100 to 5 to 15 mg per hour. IV clevidipine 1 to 2 mg per hour infusion. Phenoltopam 0.1 to 1.6 mg per kg per minute. This comes to post-ictal care. Oxygen sublimation till fully awake. IV midazolam 0.05 mg per kg to reduce the emergence agitation. A detailed record of anesthetic technique and neuromuscular blocking agents used should be made because as this treatment is repeated over weeks. Complications include post-ictal confusion, agitation, aggression, headache, reversible memory loss, dental or oral injury, nervospasm, exacerbation of ischemic heart disease. That's all.
Very good. You made all like a bullet points and completed the entire answer. Very nicely presented. I would like to ask you 2 questions on this. What is it simply called ECT or any other adjuvant adjective is there to that? It's simply called electroconvulsive therapy or is it called some other additional name? How was the ECT done in the earlier days? Was anesthesia provided to the patient before ECT? The late 50s, 60s and 70s?
Shock.
Huh? It was
Shock
done
therapy.
without any anesthesia. Okay? Because these
Okay,
patients
sir.
were all considered psychiatric patients and they will not be, they don't, they thought they will not require any anesthesia. They used to simply apply the paddles and give you the electrical stimulation in a conscious patient. And later on, it was objected because it is quite inhumane to create a epileptic seizure in a conscious patient. So they started insisting that it should be done only after anesthetizing the patient, making them unconscious. This is called modified ECT. Okay? So if you just say ECT, it is the old version of electroconvulsive therapy done in a conscious patient. So the modern anesthesia-induced electroconvulsive therapy could be called as modified electroconvulsive therapy because we have modified the technique by inducing anesthesia. The second reason why the psychiatrists did not want to give anesthesia is they thought all the anesthetic agents, because in the earlier days we had only thiopental as an induction agent. So thiopental will reduce the seizure threshold. So they thought the seizure induced will not be sufficient to create any purposeful or useful result in the patient. That is the reason why they did not want to use any anesthesia. But later studies found that giving these induction agents do not alter it much. It still produces sufficient epileptic seizures, which are quite useful for in treating this pharmacologically refractory depression and other psychiatric conditions. If you see the question itself, it is saying refractory depression in a 60-year-old man. So normally depression or other psychiatric illness like schizophrenia and phobia and all those things are all initially treated only by pharmacological methods. If they don't respond properly, then only they are subjected to this electroconvulsive therapy, which is supposed to help by stimulating the neurotransmitters in the brain and make them more come out of the depression or other psychiatric problems. That is the basis of that. And the second thing is, where is it done? Where do they do this procedure of ECT?
It can be done in a separate ECG suits or off-site locations such as post anesthesia care unit,
So it
PSU
is
or
done very
ECT.
close to the psychiatric unit or psychiatric ward. Normally, it is done as a remote site anesthesia or NORA. Okay, so that is the reason why this question is also asked in the examination. So you must make an effective impact in the answering that it is as a remote site anesthesia or a non-operative room anesthesia. That is the first point that you have to insist. And as I said in the earlier slide, you have to keep all the equipment. Soap me is the mnemonic to remember, and proper help should be there. That is the first point. If they ask you in the Viva also, you start your answer that the anesthesia given for ECT is usually a remote site anesthesia or a NORA procedure. And this person may, being 60 years old, you must say what are all the challenges that are likely to be present in that patient. Like he may have comorbidities like hypertension or ischemic heart disease or diabetes. So all these things have to be properly evaluated. You should not just blindly look only into the depressive part of it. So other comorbidities have to be thoroughly evaluated. And then a proper pre-anesthetic assessment with regard to airway and other things are done. And then only you go for this procedure. And procedure wise, it hardly takes 1 to 2 minutes. After they apply the current, the patient throws a fit. The fit lasts for maximum 3 to 4 minutes. After that, it subsides. And then the patient wakes up after the effect of the induction agent that you have given wears off, and it will be roadworthy within about 1 hour or two. So it is a very short procedure. And normally, much of analgesia is also not required because the patient is unconscious, and this epileptic seizures are not painful during the procedure. So it is not, you need not go for any powerful analgesic like opioids and other things. So I'll just share my screen to give you a visual idea about